RQ is a 68-year-old African-American female who presents to her family medicine physician for evaluation of her shortness of breath and increased swelling in her lower extremities. She reports that her shortness of breath has gradually increased over the past 4 days. She has noticed that her shortness of breath is particularly worse when she is lying in bed at night and has to prop her head up with 3 pillows in order to sleep. She also reports exertional dyspnea that is usual for her, but especially worse over the past couple of days. RQ's past medical history includes hypertension for 20 years, CHD with history of an MI in 2005, heart failure, type 2 diabetes mellitus for 25 years, atrial fibrillation, COPD Gold 3 Group D, and CKD. She was a former smoker and has a 35-pack a year history, but quit 10 years ago, and she is also positive for alcohol use. RQ's med list includes valsartan 160 mg by mouth BID, furosemide 40 mg PO BID, warfarin 2.5 mg PO QD, carvedilol 3.125 mg PO BID, pioglitazone 30 mg PO QD, glimepiride 2 mg PO QD, potassium chloride 20 milliequivalents PO once daily, atorvastatin 40 mg PO QD, aspirin 81 mg PO QD, albuterol MDI 2 inhalations by mouth every 4 to 6 hours PRN for shortness of breath, tiotropium DPI 18 micrograms 1 inhalation by mouth daily, fluticasone and salmeterol DPI 250 to 50 micrograms 1 inhalation by mouth BID. Patient is experiencing acute decompensated heart failure based on evidence of peripheral edema. She has +3 pitting edema in her lower extremities, swelling, JVD, HJR, and S3 gallop, and pulmonary edema, which is a sign which she shows through her crackles, pleural effusion, and dyspnea. She also is experiencing orthopnea, weight gain, and worsening dyspnea of exertion. Patient also has mild cyanosis of the lips and is pale based on evidence of volume overload and low cardiac output. Patient is in hemodynamic subset IV, cold and wet. ABG may be necessary to determine perfusion status. Exacerbation may have occurred due to COPD, exasperation, or due to pioglitazone, causing sodium and water retention. Goals of therapy include decreasing mortality and morbidity and increasing quality of life. An IV diuretic may be recommended to reduce her preload. A vasodilator may be beneficial in increasing her cardiac input, and nitroprusside is a mixed vasodilator which would benefit her cardiac output and volume, but it may cause cyanide toxicity due to patient's CKD. Nitroglycerin may be a better option. Patient may be needed to be admitted to the ICU for monitoring while on nitroglycerin. Our plan is to recommend switching furosemide 40 mg PO BID to furosemide IV 80 mg to manage her fluid overload. Also recommend IV nitroglycerin 10 micrograms a minute and titrate 10 micrograms a minute for 10 minutes, and the max of that should be 200 micrograms per kilogram a minute. Recommended admitting patient to the ICU for continuous monitoring. Monitor vital signs, electrolytes, serum creatinine, and INR. Monitor hepatic function with ALK phosphate and GGT for fluid status, and AST and ALT for perfusion status, and return to clinic in 7 days.